Thank you. I'm happy to be here. I hope this change in schedule turns out to be fortuitous. As you will see, some of what I will say will lead in pretty well to the whole idea of parent support, which is the next talk. So I hope I can keep you interested enough that this will flow pretty well for you. First, my disclosure statement. I have no conflicts to disclose. And then I'd like to speak for just a minute or two about why you should care about this topic. And although it says design of the NICU on your agenda, it really was intended to be more about the environment of the NICU, a more global concept of the environment that we care for babies in and that we ourselves are living in. So for the babies, this environment is a crucial period of brain growth and development. You know that, but I think we get kind of used to working in this environment every day and lose sight of how crucial that is. And I was glad that our previous speaker mentioned that, so that even when we're focused on the respiratory status, we have to understand that this has implications on the brain. And that's true for everything we do for these babies. Again, we don't think so much of this, but I think if I point out to you that this is a crucial time for families as well, you will realize the truth of that. For many families, it's an early stage of their marriage, and they learn, or their relationship, and they learn a great deal about one another going through this crisis. For many, it's their first extended contact with the medical system, and they form very strong impressions about the medical system for a long time after. Even spiritually, it's a very important time for many of our families. And the environment in which all this occurs is important. Many of you may know that post-traumatic stress disorder has been diagnosed in up to 25% of parents whose babies were in the NICU. And many of these parents look like they were handling everything pretty well, and it's only months later that this PTSD starts to show up. So it's an important time for them. And even for us, for many of us, what we do there kind of defines who we are, our mission in life. And so even for us, the environment is important in order to make us as effective as we can be and as happy as we can be. So here's the first visual for the babies. If you look at the one for 28 weeks on the upper right, that's where we get a lot of these kids, or maybe even smaller. And in the time frame that we have these babies, their brain grows in size and complexity by 400% in that 3-month period of time. That's comparable to the 400% growth that occurs from a full-term baby to adulthood. In 18 years, we get 400% brain growth, and that same proportion happens in 3 months' time when those kids are with us. It's really a remarkable period of brain growth. Here's another way of visualizing that. This is described in phases because most of the work is done in animals, but they are roughly comparable to the trimesters. And this is looking at synapse formation in the brain. So phase 1 is roughly comparable to first trimester, and you'll see not much is going on until the end of the second trimester. And then when you get to the third trimester, you get this big bang, where the synapses are starting to form. Just millions per minute is the actual number that we're talking about. And that accelerates through the third trimester into what's called the fourth trimester, the first few months after term, and then plateaus throughout childhood. So it's a remarkable period of brain development that's happening. And where that's happening is also important to know. So on the left-hand side, you have adults, and where synaptic formation is occurring for us is primarily in the areas that are associated with information processing or learning, what you're doing right now. But for babies, where all of these synapse formation is occurring is happening in all the sensory parts of the brain. So visual, auditory, sensory motor, that's where the action is. And again, it's for better or for worse. So we may not pay attention to it, but it's happening to the babies, the light, the sound, the touch, or lack thereof. All of that's happening under our care. So to take the next step then, how should we think about these babies' brains that are so actively forming? First, we need to be sure we have really dispelled some of these myths that we held on to for a long time. We thought of babies' brains as being a blank slate, and we were just now starting to give them experiences. But in fact, that's not true. A full-term baby who is born can recognize both mother's voice and the smell of her breast milk within the first day of life. So this is not something that got learned after birth. This is something the baby learned in utero. And that same learning process is happening with us, but they don't come to us with an empty brain. It's already full of information and experience. We think of babies' brains as extraordinarily resilient, and indeed they are resilient. If you have a stroke in a baby and a stroke in somebody my age, the difference in outcomes is pretty dramatic. Babies will do much better, but they're not infinitely resilient. So we can't let bad things happen to babies and expect that somehow they will do fine through that. If they have a stroke, they will have sequelae. They may not be as severe as for an older person, but they are real. We think of babies as being at rest during sleep, and all the rest of us are. We don't learn during sleep. We consolidate memory during sleep, but babies actually learn, which is good because they're asleep most of the time, at least if we let them. But during that sleep phase, they are in fact gaining new experience. So if a baby looks like they're asleep and they hear our voice, they get an unpleasant smell, they are disturbed by a light, that's all a learning process for them. And then we think of babies as too young to actually have memories. Again, I've pointed out this happens even in utero. Just because they can't recount those to us later does not mean that they don't get sensitized and habituated to stimuli. That's been shown very clearly. So we have to start thinking about now the baby's brain and the environment that it was meant to develop in. There are two types of mammals. There are precocial mammals. These are ones where, at the time of birth, they're able to move away from danger, move towards food or safety with their mother, but they can kind of fend for themselves. Think of horses and goats and mostly hooved animals. Altricial mammals, however, can't do that. They are entirely dependent on their mother for nutrition, for safety, for warmth, for hormonal stimulus, for all of the things that are listed here. And we are altricial mammals. We can't change that. Just by putting babies off in an incubator and pretending that they can be isolated from their mother without consequence is a fallacy. And we have to understand that. We were not built that way. So kangaroo care is not just a nice thing to do. It has something to do with the best environment of care for our babies. And if we look at each of the sensory stimuli and try to compare what the baby would have gotten in utero, what the optimal sensory stimulation would be, and then look at how that might happen with the baby in the arms of its mother or father or some human being versus in an incubator, it's no contest. There's no question that being in mother's arms is the ideal place to be. And I'll say here, I know that this conference is sponsored by somebody that makes incubators, and I will say they understand this too. And every incubator manufacturer knows that their incubators are not the ideal places for babies, and that's why they're going to try to make them better. They are working to make better incubators. But the reality is they're never going to get one that replicates mother's arms, just like we'll never get a formula that replicates breast milk. And so we have to understand how big the difference is between mother's arms and incubators. And let's talk about incubators some more because we have some myths there too. First off, we think of incubators as these places that are really nice for temperature control. They can precisely control a baby's temperature, and that's really good. And compared to the alternative before incubators were developed, that's true. But if we think about a couple of things, we'll realize that maybe incubators aren't quite as good an environment as we used to. First off, when you set the temperature for the set point for your incubator or your warmer, you're picking a number, 36 to 36.5 usually, that was based on research that was done back in the 1970s. And that research looked at caloric expenditure by babies under different temperature conditions. And it's a U-shaped curve. So if the baby's temperature is colder, they use more calories trying to stay warm. And if it's warmer, they use more calories trying to cool off. And the bottom of this U-shaped curve is where they use the fewest calories, and it's what's called the thermal neutral environment. So that was chosen with the concept that if we minimize the calories they're using just for their basal metabolic needs, we will maximize the calories available for growth. And that all made sense as far as it went. We have to reevaluate that assumption, though, when you realize that in utero, babies are actually about a degree warmer than that, and when they're held skin to skin, they're usually about a degree warmer. So what's going on there? Is there some biological reason that maybe we should be thinking about a warmer temperature, particularly when the baby's skin to skin? Well, when you realize that the brain is the most metabolically active organ in a newborn, and then you ask, do we want that running at the lowest metabolic rate, or maybe it should be a higher metabolic rate because we want a lot of good stuff to be going on there, you realize that maybe the thermal neutral environment that we've picked for incubators might not be the ideal one. And holding a baby skin to skin with the mother where they are about a degree warmer may be more desirable for brain growth and development. The other thing about incubator temperature control is it's really good at keeping kids at the same temperature, but that is not natural. In utero, babies have a diurnal cycle in their body temperature. Every single living organism has a diurnal regulation of their body temperature. And that's true after they go home. The only human being who does not have a diurnal variation in their body temperature, unless there's something really screwed up in their regulation, is babies in incubators and on warmers. So maybe one of the things when we're building new incubators is we should allow babies to have a circadian rhythm, or at the very least, we should have information from our incubators that tell us how much power it's taking, how much temperature it's taking to keep babies at a particular temperature, so that we know and we can judge better what the appropriate set point and whether we can dial in some circadian variability as well. But that isn't available today. We also think of incubators as optimal for infection control, these nice, safe places that we can put babies away from all the bad bugs of the hospital. But the reality is that after one day in an incubator, if you culture the outside, the inside, any part of an incubator, you will find plenty of hospital pathogens there. You will not find probiotic organisms. But if you put the baby skin to skin with the mother, although you may find MRSA in some moms and you may find some E. coli, you'll find some pathogens there. What you will also find is probiotic organisms. And if babies get those probiotics, they can fight off the hospital pathogens. So it's not even the ideal place for infection control. And there are other things. For example, we have a big electrical coil in the base of that incubator that puts off electromagnetic radiation. And we don't really know if that's safe for the developing brain yet. So this is not to tell you we can't use incubators. This is just to say we need to think of the optimal environment for babies as something beyond the incubator. And that is being in the arms of the mother. So I'm going to give you a rundown of some recent data in this regard, because, again, I think it's been looked at as kind of a nice thing to do, but most of us haven't been aware of the extent of the data that supports getting babies out into their mother's arms. And trust me, eventually we will get to NICU design for those of you who are really interested in this. But we got to start with the microenvironment first, the immediate environment around the baby, before we talk about the macro environment, the big unit. So the first study I want to tell you about was done at Rainbow Babies in Cleveland by Dr. Scher and his group, which showed that if you keep babies skin to skin for 1.5 hours a day, 4 times a week, after 8 weeks, you will be able to show that there was increased maturation of their EEG. At Karolinska in Sweden, they did a study that showed if you make it possible for families to be present 24/7 with their babies, that you will get a marked decrease in length of stay and incidence of chronic lung disease. And I'll tell you a little bit more about that study in a few minutes. Also from Scandinavia, a study showed that just training parents about the neurosensory needs of their babies somehow changed how they behaved with their babies and ended up with improved white matter development on CT scan done at term equivalent. Cochrane reviews show that infant massage by parents improves baby's weight gain. The bottom one is the study that showed that newborns learn during sleep. There's a nice study with the initial report in 2011 and then the follow-up just this year, which showed that exposing babies to their parental talk increased the baby's ability to vocalize and their language and cognitive skills at 18 months. Another study showed that kangaroo care reduces DSATs, and a lot of us have anecdotal evidence of this, where we know babies did better in that regard when they were being held skin to skin. A recent study from Ruth Feldman, who's done a lot of this work over in Israel, showed that skin to skin care in the first 2 weeks of life improved executive functioning and mother-infant reciprocity, the interaction of mother and baby at 10 years of age. So now we have long-term follow-up. This is not just something that's nice at the time. It's not a big surprise, but this has long-term implications, like lots of other things that we do in the NICU. And another study below that showed, even in adolescence, that pathways in the brain were improved in those infants who receive skin-to-skin care. Another Cochrane study just released this year, or just updated this year, showed that kangaroo care improved mortality, sepsis, and length of stay. And recently, the next step after kangaroo care and family-centered care is this concept of family integrated care or family nurture intervention, which really gets the family involved not just with holding the baby, but actually helping with feedings and respiratory care and all of the care of the baby. And when you do that, you get improvements in EEG and weight gain. And then these last two studies are interesting because they show how critical this is in the first few hours of life. So the study by Bystrova et al. Was done in a randomized controlled trial where they had 3 groups. In the first group, it was kind of standard care where babies were separated from their mother during the first few hours and then taken to the nursery. Mother went to postpartum and they could be together, but they weren't rooming in. So when mom was interested, she would have the baby, and when she wasn't, the baby went back to the nursery. The second group, they separated mother and baby after delivery. Mother got to see the baby but not hold or do anything. It was the usual that most of you are familiar with, that the baby goes off in a crib and the mother's in her bed. And then after the 2 hours or so when they go to postpartum, then they were allowed to room in. And then the third group, they allowed the baby to be skin to skin with the mother for that first 2 hours and rooming in after that. And what they showed was that the babies who got the skin to skin in the first 2 hours of life did better on self-regulation, maternal sensitivity to the baby's needs, and this reciprocity. If they got that first 2 hours of skin to skin, then if that was skipped, and even with rooming in. So if you separate mother and baby in that first 2 hours, even if you give them rooming in afterwards, you don't get all of that benefit back. It's better, obviously, than separating them extensively, but that first 2 hours is really crucial. And that's the time we in the NICU are doing all of our stuff and feeling that we're really doing something important for the baby. And for many babies, that is indeed the case. But to the extent that we can, we need to start thinking about leaving those babies with their mothers if they don't really need us. If they don't need to come over and get their vital signs done and observed at a time when they could be with their mother, we need to start changing that practice. Well, all of this is an example of some human studies, but there's a huge body of evidence in animals that shows how important this is. We don't see it because it isn't in our literature, but it really is a massive body of evidence to show that babies need to be with their mothers. This isn't a new concept. Even back in the 70s, some visionary neonatologists were talking about that. It is something that we have a long way to go. So in utero, babies are skin to skin 100% of the time. In the Stockholm study that I'll tell you about shortly, they got it up to 70% by making a place available where mothers could be with their babies 24/7. In our typical U.S. centers, it's more like the 1 to 3%. On the right, a typical U.S. center is one that is actually interested in skin-to-skin care and willing at least to measure what they're doing. And this is what several centers participating in a Vermont-Oxford NICU project found at the beginning of the project. We were part of that project, and with 6 other hospitals, then spent the next 18 months trying to increase our skin-to-skin care, and we tripled it. We got from 1% to 3%, which we shouldn't be too ashamed of, because remember the very first study I showed you, 1.5 hours a day, 4 days a week is enough to cause improvement in the EEG maturation, and that's about 3% of the time. So we have a long ways to go, but we certainly should get started. So to summarize this part of the talk, what we know today is that all infants suffer in the absence of this extensive, intimate contact with their mothers. We know that skin-to-skin care has been effective in every culture in which it's been studied. You can show it in Africa and Latin America and Sweden and even in Cleveland. We know that most of our current NICUs were built without much consideration of these findings, and even in the newer ones, sometimes we have not done a good job of recognizing and responding to this science. So we need to change our practices in that regard. But that's also true of the environment for families and caregivers. There's a lot of data out there about how the environment, daylight, smells, sounds, lights, affect all of us in our workplace and in our care of family members. And yet hospitals, which really ought to understand this better than anybody, don't do a very good job of incorporating that. So why don't we know all of this? Well, a lot of it is in the other literature that we don't read all of the time. But when you put all that together, here's the working premises that I think we could all agree on. Babies deserve the best available treatment. Babies and their parents should not be separated, either because of inadequate space or restrictive policies. And in some of our hospitals, both of those are true. The commitment of a mission-oriented hospital to babies and families should be greater than any other part of the hospital, because the stakes are higher in the NICU than they are anywhere else. And many of you work throughout the hospital and understand that great things happen everywhere. But the brain development aspect of this is something that happens nowhere else in the hospital. This is by far the most important place to get it right. And it should meet the needs of everybody who's there, not just babies, but families and us as caregivers. So that gets us to single-family room. How many of you work in units now that have single-family rooms? About a third, okay. It certainly is the developing trend. Private rooms are the standard everywhere else in the hospital now in the United States, and they certainly are developing trend in NICUs. They have a lot of good things about them, but they certainly have some potential pitfalls too. So we're going to talk a little bit about that. The rationale for babies is that we can individualize the lighting and the sound. We can do a better job of infection control. We can more suitably support families who are interested in doing lots of intimate care with their baby by giving them the privacy and the space to do that. It's the optimal environment for most families too. It gives them privacy, a sense of control, a sense of belonging. And even for us, it allows us to have our space and the baby's space instead of it all being together like all of our old units were designed, and us having to make sacrifices in terms of the music we'd like to listen to, the conversations we'd like to have, things that we have to sacrifice in order to make the environment as best for the babies as we can. But in a single family room unit, that's not necessary. This too is not a new concept. Even back in the Middle Ages, I didn't put that in there. But that's a nice touch. The other nice touch on this is if you look up in that left side, just to the left of the big stained glass windows, that's the pulpit where the neonatologist stands and tells everybody what to do. Okay, so the current database, we have a lot of adult and pediatric units that have shown us that you can put patients in private rooms and they aren't going to all of a sudden go bad on you, and that this will be unsafe. And there are plenty of NICUs out there that have demonstrated that this is practical and safe. But there are pitfalls. A bad NICU, a bad single-family room design can actually be worse than an open design, and we'll talk a little bit about how that might happen. So the concept really is single-family rooms, not single-patient rooms, because the family is an important part of this concept. This is the study from Stockholm. So what they did there was to move from an open design to all private rooms. They had their NICU on 2 floors, and in order to do this study, they renovated 1 floor into all private rooms and then stopped and ran the study. So 1 floor was all private rooms, 1 floor was their open design, same doctors, same nurses, same patient population, just randomized to one or the other. And what they found was that in babies less than 30 weeks gestation, the length of stay during the intensive care portion of their stay was more than 10 days less in this single family rooms. And their incidence of BPD, which was already very low, part of that is because these units only took care of kids up to CPAP and sent them to another hospital for ventilator care. So that's part of why their baseline is 6%. Part of it is because BPD is less common in Sweden anyway, for a number of other reasons. But in any case, you can see that their BPD rate went down dramatically, even from as low as it already was. So these are pretty impressive results, just by making it possible for families to be there 24/7. This is a study from the United States, from West Virginia. These were older kids, and you'll see that their length of stay did not change, at least not to the degree that was statistically significant. But they did see a reduction in apnea, a reduction in the number of days on TPN, an increased number of days that mothers were able to provide breast milk, reduction in sepsis, reduction in noise levels. So it's better for babies. How about some data to see how it works for families? This comes from South Dakota's unit, which is all private rooms. And in this case, they did historical controls, so they went from a unit that was all open to one that was all private rooms, and saw a dramatic improvement in the family satisfaction. They felt that this was much more friendly to their needs, and it had kind of this halo effect where they felt like the staff worked better together. I don't know if they did or not, but the families thought they did, and that counts. And they thought the care given to their baby was better and to them was better. And they found, in looking at costs, that they had a total 15% reduction in costs after they moved to the single family room. So they didn't break this down by length of stay, for example, or BPD as was done in Sweden, but they found a similar cost benefit. At Vanderbilt, they had what's called a hybrid unit, where they have some open area and some private rooms. And they talked to parents who were in both of those settings and found that those parents liked the private rooms better, and particularly that they were more likely to be present during rounds. So physicians rounded it in both sides the same way, but they were more likely to find parents there and willing to participate in the medical decision-making in the private rooms than they had been in the open area. But this privacy concept is the other side of a coin, which is isolation. And if we're not careful, we can give people too much privacy. We can isolate them, and that's not good for some babies and some families. So the study that many of you heard about was done at St. Louis and showed that in their private room setup, the babies that were in the private rooms had poorer language development than the babies who were in the open area. What you need to know about that arrangement was that they didn't encourage families to stay, and they really didn't build their NICU in a way that was conducive to families staying. So it didn't have a bed, just had a recliner chair that was right next to the baby's bed, which, if the baby's getting care in the middle of the night, isn't very conducive to families sleeping, so families generally didn't stay. So these babies in private rooms, they were not single family rooms, it turns out. They were single patient rooms, and they were off in isolation, and they didn't hear any voices. And so just like the flip side of the study, I showed you that if parents talk to their babies, it improves the language development. If you put babies off in a room by themselves, it interferes with their language development. So this is one of the pitfalls of single family rooms. It works that way for staff too. So this study was done in St. Paul, and let me go back to that for a minute. On the right, you will see the single family room. On the left, you will see the hallway, and those little decentralized nurses stations outside of each room are the only places nurses have to gather. They got rid of the nurses station. The idea was, this is the new thing. We won't have a central nurses station. We'll have all the nurses at the bedside. Well, they asked nurses how they liked this, and what they found was that the private room was indeed better for their own work environment quality, for their ability to give good patient care. They even thought their quality of life off the job was better since they moved to the private room unit, but they thought the open bay was much better for interaction with other members of the NICU. And that's pretty logical because they didn't provide any space for that to happen. So if you build an all-private room unit and you don't build a central nurses station for nurses to get together, they won't even know who else is working that shift with them many times. And they certainly won't be able to communicate with them the way you do in an open unit. So that's a pitfall if you don't get it right. We really should think of having some open space and maybe not building every room as a private room. We've talked about this when the families aren't there. Maybe those babies need to be in a more open space, at least when they come out of their incubators into cribs. Some families may prefer to be out in an open area. Niels Bergman, who is one of the big kangaroo care advocates, is from South Africa, and he says in South Africa, if you're put in an isolation room, that's like punishment, because in their culture, everyone wants to be together. I remember visiting a unit in Madrid that was an old unit. It was built in the 1950s, and this room was full of mothers breastfeeding their babies, and they did not seem to care that it was out in the middle of everywhere. That's the environment that they wanted. But for most of us, we would rather have that privacy. We just have to know that that may not always be the case, particularly if we're in communities with a diverse culture. And even for twins or triplets, it would be nice in those cases to put those kids into the same room. So I think there are some reasons to think about building some rooms that have space for more than one baby and family. Think about single family rooms with parents as a home, at least a home away from home, and a way to provide neuroprotection for the babies. And I'll mention this a little bit more in a minute. And a single family room without parents as being kind of an isolation cell. So neuroprotection is a hot topic right now, and we do a lot of cool stuff with therapeutic hypothermia, but there are a lot of other important ways to provide neuroprotection. let's talk about some of those that have to do with mothers. So getting normal flora into babies is important, and many of you are aware that some studies are going on with probiotics. One of the best sources of probiotics, and you don't have to get an FDA approval for this, is to put babies skin to skin with their mothers, because the probiotics are right there on the mother's skin, and the babies will pick them up if they're skin to skin. Mother's milk has things in it, has bioactive substances in it that we can't put in formula. Some of them we don't even know to put in formula, but we know the brain development is enhanced in babies who get mother's milk compared to formula. So that's neuroprotective. We know that the appropriate sensory stimuli are neuroprotective. And we've talked about extended maternal contact. I showed you all the studies on that. The cool thing about this is that if you do the extended maternal contact, all the rest of this gets better. So if babies are in contact, they'll get the normal flora. Mothers will do a better job of producing breast milk. They'll get the right sensory stimuli, and you get this virtuous cycle going. So that's the visual for neonatal neuroprotection. I'll speak just for a couple minutes about developmental care. It's a hot topic, and the previous speaker actually mentioned Goldilocks. So here's the Goldilocks concept of developmental care. On each of these sensory modalities, we can do too much or too little for babies, and we often do. So if we talk about auditory, the kind of noise that we have for babies, even inside incubators, the decibel level is higher than what's been shown to interfere with infant sleep. That's too much. Sticking them off in an isolation room by themselves, that's probably too little. Getting it just right, they need to hear some normal conversation. Maybe music is beneficial. You can imagine what that might be, that's somewhere between those extremes of silence and noise. And you can go down that list and see that in each case, you can probably identify something that's too much and too little. So the Goldilocks concept is that if you put the kid skin to skin, you get all of that just right. The baby's visual, auditory, touch, smell, movement, it's all about right with skin to skin, whereas there's no other way we can get it just right in our environment otherwise. So here's the analogy that I think that I touched on briefly at the beginning that I think is really useful. There was a time back in the 70s when I was going through my training when we thought infant formula was the way to go for premature babies. We knew that breast milk was not sterile. We knew that it was inadequate for the nutrition of premature babies. It did not have enough protein or calories or calcium or phosphorus, and it was just a hassle to use. Whereas with formula, we could get the protein up, we could get more calcium and phosphorus, it was sterile, it was very easy to switch the recipe around if we wanted it. It was the best way to go. And the only time we gave breast milk to babies back then was if we had a hippie mom who insisted on it, and even then we made sure to tell her, but we have to warn you, this is not the best thing for your baby. And think how different that is today. So breast milk still doesn't have enough calories and protein, and we have to fortify it, but it's still what we're using as our base because it has so many other good things in it. And we only use formula if we have to. I think this is the same place, the same concept, just a much earlier stage where we are with skin-to-skin care. So right now, we think of the incubator as a warm, secure place for babies, and mother's arms as a hassle and risky. But in the future, I think we will understand that incubators, while we may need them some of the time, are not the ideal environments for babies. They get no human contact there, and we'll use them as little as we can and put babies in mother's arms as much as we can and see that as the optimal environment for babies. So developmental care involves 3 steps. First is creating this nurturing physical environment for babies, families, and caregivers. And you can do this wherever you are. If you have a new unit or an old unit, you can make it more nurturing for all of us. The second is getting babies into their parents' arms. And then finally, using the principles of developmental care. And I don't think it's as important whether you use NIDCAP or WeCare or one of the other programs, as that you really are committed to developmental care as a unit, and that that's your culture. For those of you who might be planning new units, who came to this talk thinking they might learn something about NICU design, let me just stick this one in. And for the rest of you, just to keep in mind someday, hospitals do a pretty lousy job of lifting our spirits. And we know how to do this. If you go to a hotel or a cathedral or an airport, you will see lots of light, lots of movement, lots of space, lots of color, lots of curves and other shapes that are not angular. But you go into a hospital and most of that's missing. And that's really a shame, because that's part of the healing process. So if we design our hospitals just to be functional and we leave out these things that nourish the spirit, then we're treating us and our patients as something less than human. So here's the elevator speech for you. Again, there is nowhere in the hospital where it's more important to get it right. Lots of good things happen everywhere in the hospital, but nowhere are we building brains and building families like we do in the NICU. And this is happening for better or for worse. Whether we care about it or pay attention to it or not, it's happening under our care. So here's some resources. There are recommended standards for NICU design that have been published in the Journal of Perinatology. There's a couple of issues of Clinics of Perinatology that really have extensive information on all of the sensory input that's important. So if you want to learn all about taste or movement or lighting for NICUs and how it affects babies, it's in those. And then the Gravens Conference is a great conference for a lot of this up-to-the-minute information on what's the newest on these topics. Okay, that's it for the talk, and I don't know how much time I have for questions, but I'm available. Oh, no, I'm okay. I do need to go eventually, but I'll be fine, thank you. Yes? Our current NICU is 36 beds, and it's not a single-family room unit. It was built in 1986. We're in the process of designing a new one, but we don't have it yet. Yes? Okay, so the question is, when is a patient too critical to get skin-to-skin care? And I think there's a couple of answers to that. The first is that most patients who are immediately post-op are probably not suitable for skin-to-skin care. They're connected to a lot of things. They're sedated, so they're not going to be getting much benefit of this contact with their mother, and that's probably more downside than benefit, at least for the first 24 hours or so after surgery. The second is the baby who doesn't tolerate skin-to-skin care. And I say that way because for almost every other baby, it's worth trying it. So we have been surprised by babies who are having a lot of instability, a lot of apnea, and we said, well, let's just try it. The worst that can happen is the baby will desat or show some other sign of instability, and we'll have to put them back in the incubator. And much more often than not, the baby actually gets better with those areas of instability when they are skin to skin than they had been. Now, I have to also add that this is often a two-person undertaking and occasionally a three-person undertaking, because it is possible to dislodge an umbilical artery catheter or an endotracheal tube or something else that you really would feel very badly about if you lost. But if you do it right, you can do it safely, and you will find that most babies tolerate it very well. We certainly do it with babies who are on the jet, who have lines there really are minimal restrictions beyond either a baby who's immediately post-op or a baby who has already shown by trying it at least once that they're just not going to tolerate it yet. Yes? Just try it. It really is a 10 or 15-year process, I think, and we have a few therapists from our unit who can vouch for this, that it took some brave nurses and some really dedicated parents, and then we got braver the next time and the next time. But I'll tell you what happened that made the biggest difference, I think, along this journey was at one point, how many of you have heard of a technique called appreciative inquiry? Okay, well, it's worth, how many minutes do I have? Okay, it's worth just telling you about appreciative inquiry because it's cool. Appreciative inquiry is a way of addressing issues that's quite different from saying, we have a problem, here's what the problem is, here's what we're going to do to fix it. Appreciative inquiry says, here's what we do well, and we want to do it even better, and let's figure out what we're good at and figure out how we can get even better. So instead of a negative, we've got a problem, we need to fix it, it's a positive. We're pretty good at this, but we want to get even better. So we had an appreciative inquiry session on skin-to-skin care and invited families to join us. And the most powerful part of that came from a mother who had lost her baby, and the baby was critical. The baby, at that point, the day before he died, we didn't know if he was going to live or die, and there were some nurses who were very reluctant to stress him by letting the mother hold him. There were some nurses who were saying this mother is already too stressed out and she'll just transmit that to the baby, and that she should go home and get a break because this is going to be really hard on her, whatever happens tomorrow. But eventually we did let the mom hold that baby. He did die the next day, and she came back and told us during this appreciative inquiry session how important that was for her, how much it meant. And the nurses who had been skeptics about that before really, and respiratory therapists, because they're part of our team and are essential to make this happen. Certainly for this kid they were. They understood then that we may have reservations, it may be a hassle for us, but for the parents, this really, really is important. And as we've been doing it more, we've been getting more of those testimonials unsolicited. So when we send out our surveys, parents will say, it was so nice that I could hold my baby, and that's continually reinforcing. So the short answer was, just do it and learn from it and start with the bravest nurses and the bravest families and get comfortable with it and help reinforce it. And it will take a long time. It is not something you can change immediately, but you just got to start somewhere and then build on that. Okay, thank you.